Hello and welcome to my channel. My name is Peter Abraham. I'm a registered nurse with a background in cardiology, med-surg, long-term care, and mostly hospice. This channel deals with a variety of related topics. So end of life, also involving what families go through after their loved one dies, anticipatory grief beforehand, grieving afterwards, different topics involving chronic illnesses that become terminal. Book writing from the perspective mainly for supporting hospice nurses, holistic nurses, mind, body, spirit, soul, and caregivers. As a book author, I have written multiple books, and I enjoy sharing them with you. And so if this is something that you like, comment, subscribe. If you're new here, welcome. So before I go into today's topic, which is overviewing the second chapter of an upcoming book, it's in draft format right now, Hospice Clinical Pharmacology, Comfort, Critical Thinking for Comfort-Centered Care. I like to start each episode over looking at areas of what are we grateful for. I encourage each and every one of you to ask yourself the question shortly after waking up. If you need to have a cup of coffee, whatever you need to get yourself going in the morning, ask yourself, what are you grateful for? What am I grateful for today? Because one of the lessons that I've learned as a hospice nurse, I've learned many lessons, but one of them, when you're dealing with death and dying on a daily or very regular basis, is that if we are not resilient is that ability to snap back. It's like being like a rubber band. If we get stretched thin, we're not breaking, we're snapping back. One of the things that helps is to be as grateful as you can be. So for myself, our last shooting was this past Friday in terms of a video. Since then, our gardening, I was almost tempted to do a mini video, but I wanted to keep this short, even though from a point of view, it's going to be a close to a half hour or so video. But our leafy greens are blooming to the point where we could probably be having salad from them later this week, if not today. So this is our first time my wife and I are gardening. We are doing this from scratch. I do appreciate the comment the other day about investigating bone meal. So thank you for that. This is a brand new adventure for us, both gardening, raised beds, and then life in central Kentucky when we spent our entire lives in Pennsylvania, or at least most all of my life, all but 15 years of my wife who came from New York. But I'm grateful that the plants are blooming. I'm grateful for all my friends on LinkedIn. I have several. Julian, if you're watching these videos, I'm humbled when somebody reposts some of my posts on LinkedIn, Facebook, Cassie, Ed, Joe Ellen, and many others who share my posts that promote the books that I write. So I'm grateful for that. I want to try to avoid going down rabbit trails, including how grateful for this and that, and I spend hours on gratitude. I want to value your time. So the book that I'm writing, Hospice Clinical Pharmacology, is tightly focused on pharmacology at end of life. So I am using 3 of the books that I wrote as some of the references. So we have Whispers of Time, that takes a very tight view. This is like the Barbara Carnes has gone from my site for caregivers. This is my equivalent for hospice nurses. My equivalent for hospice nurses, so Whispers of Time. So that's looking at the last several months to last 2 weeks of life. The Art of Hospice Prognosis, which there are evidence-based methodologies using our 5 senses without lab work, without scientific tests. There are ways to know approximately when somebody might die. and medication reconciliation for in hospice care. So this book mainly deals with this deprescribing topics, but it is necessary as part of the pharmacology. So I've been working on this book. I've previewed before the introduction in chapter 1. What you're about to see shortly is an overview of the second chapter, looking at our renal system. We excrete most of our medications when we urinate. So I did watch a wonderful hospice-oriented webinar that looked at medications we need to be very careful about when we're dealing at end-of-life topics. And one of the doctors of pharmacology in that webinar shared, we should always assume, I know what some may say, we'd never assume, we should always assume all of our hospice patients are CKD stage 3, even if we don't have a formal diagnosis. I'll go more as we go deep dive into this chapter. So I'm going to switch over to the overview of that chapter, and then we'll come back for the outro. Continuing with the review of the draft of Hospice Clinical Pharmacology, Critical Thinking for Comfort-Centered Care. This is the second chapter. It's dealing with renal pharmacology basics. Most medications we excrete when we urinate, when we pee, and so that does impact the drug interactions in our bodies the closer that we get to death. So this is just going to be just an overview. This is just a draft of this chapter. So for every chapter, we have learning objectives, and then we dive in. So part of how our kidneys impact pharmacology is we have reduced kidney function. And that should be, and I don't know how to word this, I'm not a fan of assuming anything in life, but when we're talking about patient safety and improved outcomes, even when we don't have a confirmed diagnosis of kidney failure in our hospice patients, we should be assuming CKD stage 3, and I'll go over why shortly as we go down the chapter. But how does this reduced function, how does our renal function impact pharmacology? Well, we have reduced filtration. The half-life of the medications are prolonged. For those of you who are new to half-life, let me use morphine as an example. That's my favorite medication for most hospice patients. Morphine's half-life is 2 hours in healthy people. So if you give a 10 milligram dose of morphine at 8 a.m. in the morning, in 2 hours with normal kidney function, they will have 5 milligrams remaining in their body. And so by 10 o'clock, they're going to have 5. By 12 noon, they're going to be at 2.5. By 2 p.m., 1.25. And this is going to continue until it's completely out of their body. And that's why a number of hospice providers will have the morphine, Q2, for example, to refresh, or why some providers, when they're crashing, let's do every hour just so that we don't have that. And again, keeping in mind at that point, if they're crashing, we're not as concerned with renal function. We want to avert the crisis. When you have prolonged half-life, you do have unpredictable levels, and granted, we're not doing blood tests in hospice. You have changes in how the drug is distributed. When you have somebody who is heading towards death, their heart is decreasing in function, their liver is decreasing in function, they're going to have edema and third spacing. Uremia is going to impact the albumin levels, and so on and so forth. So here it goes over some classes. If it's water soluble, urinating it out more. Primary is going to be renal clearance, and that's going to be your medications like gabapentin, pregabalin, which is your Lyrica, by the way. Medications with active metabolites. This is where morphine, my favorite med, one of my favorite meds, becomes an issue. nephrotoxic agents like NSAIDs, aminoglycosides, and drugs that are highly bound by protein like phenytonin. So why do we need to presume our hospice patients are at least CKD3, even if it's not a formal diagnosis? And we're dealing with age-related decline. The part of the natural decline, even when somebody doesn't have a terminal illness, I'm going to be 62 next month. I have to remind myself to drink water throughout the day. And when somebody is terminal, you know this, that they're drinking less, and we're going to encourage but not force. So dehydration, hypoperfusion, the heart, lungs, and kidneys are like your three sisters with the traveling pants. They just love one another. It's not about the pants. That's that interaction with one another. So if you have heart issues, you're gonna have kidney issues. Lung issues, you're gonna have kidney issues. It's all around. And when somebody is dying, it is going to be multi-organ failure, especially if it's slow and progressing. My experience. Clinical evidence in terms of the studies out there, the 30 to 85% of some type of renal impairment. Granted, we only do autopsies after the fact, risk-benefit analysis. Then in terms of all my books, I try to write from the perspective of where I came from. That's good and bad. So I'm putting my biases out there right now. I come from a rural hospice background where I'm traveling anywhere from 10 to 15 minutes to an hour or more to see a patient at home, where if we do get lab values, if they allow us to get a stick, and we do get lab values, it's far and in between. And while we may get portable x-rays for like to confirm aspiration pneumonia, uh, we're not doing a lot with portable imaging. So we need to learn how to look at things with all of our senses to determine what they're going through. So your output can get tricky if they don't have a Foley, but we can go. They soak the entire uh, adult. I hate using the word diaper, but adult brief. The bed soaked, or gee, there's not a spot for over a day. We can look at edema, look at mental status changes. Are they itching? Are they having twitching and cramping? And then some drugs to avoid. And when I say avoid, the doctor is going to have the final say. So as I'm writing all this, we need to. It's a catch-22. On one end, there's a level of stay in our lane, but then there's the other end of we are called. We are called to speak out to our providers, to do education, and to say, hold on, please, I have a concern here. And so we're called to be that front line of, should there be another way to approach this, with the understanding that this is not about winning, and this is not about being right. We're looking out for improved patient outcome, patient safety, patient comfort. So that's what we're looking at as we're going through all of this book, any other book. Forget the books, life as a hospice nurse. So it goes over the medications that are at higher risk, goes over safer alternatives. I know many of you, especially like if you're like me, that you come from the hospital environment, and you see the third bullet point, hydromorphone, which is Dilaudid. They're asking for Dilaudid, and there are so many pros. So we should never get jaded. I encourage all of you, especially if you're jaded or getting close, please. Hospice is a whole different mindset. We're looking at patient comfort. And if I have a former drug addict, they're going to need more. I'm going to treat them for their comfort, not where they came from. We need to look at where they're at now. What do we need to do now? Not judging or being jaded. Other alternatives, and I realize some of these might be Lidocaine 5%. Are you kidding me? You're just tickling their pain. I shouldn't even say tickling. You're not touching. So there are going to be cases where you're going to have this discussion with the provider, and the discussion might jump from here to there. You might even jump and ignore some of this. I don't expect any of my material to be, quote, the Bible. It's just to help you and your team to bloom, to grow, to excel, to brainstorm, to give you other thoughts out of the box, and or to verify and help you. Yes, I'm on the right track because you are a good hospice nurse. So some clinical examples of what this looks like. And when we get to the chapter, next chapter after this is going to be looking at the hepatic, the liver, and the chapter after that's going to be cardiopulmonary. When we get to cardiopulmonary, I do want to address what we've probably all been through. I know I have. I still remember one of my heroes, and I'm sorry, I'm trying not to get emotional because I still remember him vividly. Uh, Keith and Teresa. Keith was the patient, and Teresa the wife, and I was literally the only hospice worker that they allowed in. And I don't think it was because of me. I'm not trying to lift me up, but they wouldn't allow the social worker in. They didn't want an aide. They I should say they tolerated me. I couldn't get more than once a week visits, and even that sometimes was challenging. But getting back to the pharmacology aspect, when I get over to the heart failure, we were working with torsemide, increasing doses, and even got into metalazone to boost that up. And towards the end, nothing was working. Edema getting up to his hip, and this is one of my few patients that was. We were fighting, were they going to die from drowning in their fluids? So I do want to address that elephant in the room when I do get to that chapter. But until then, with furosemide and we're dealing with renal, you may have to work with the provider on upping the dose. We all should be aware of start low, go slow again, except for crisis. Keeping the regimen simplified and reassess regularly. Now, regular reassessment can be very, very challenging for hospice nurses. I have been there. I still remember as a rural hospice nurse when I had 8 patients the one day, all spread out, and you thought 12-hour days in the hospital was hard. When you're driving and you have your micromanaging sometimes, clinical managers calling, you have to go back, and you're like, I just left there, but you have to go back, and you're inside your head. You're thinking I'm a mobile ER unit, and I don't even have. I'm not an emergency nurse. I don't have that level of training, but yes, and you're running around. It can get exhausting, but we need everything at the end of the day, patient-centered care. We need to focus on. We have to care for ourselves. We have to set our boundaries, but at the end of the day, it's all about the patient and their family. Improve patient outcomes. So regular review needs to be there. And even if you're going to see the patient, I just saw them yesterday. We can never, and when I say never, I am not perfect. I've made mistakes. So don't ever take this as judgment. I am not judging. But we need to focus on them. And even if we saw them daily, we need to have our, well, what if it was the med? What if it was this? What if it was that? Take the time as hard as it is and be kind to yourself. So every chapter, this is the chapter from now on, it's me. The previous chapter was going over the pharmacology basics. So every chapter is now some meat in terms of 4 or 5 case studies on how you would approach things. So this is looking at antibiotic selection. And I've had a lot of doctors like Cipro because I want to knock it out. And if they're at the 4 to 6 month mark, that could be appropriate. If they're so close to death, you want to be a little bit more careful with that. And one thing to remember in terms of pearls of wisdom with antibiotics, antibiotics, if it's the right one, should be kicking in within uh, 2 days, 3 days max. So if they're giving it appropriately, and with this, here's fine print. I still remember the case in late 23, very early 24, where I had a patient that was close to the 1 month mark, and put it. It always needs to be in the hands of the POA. We don't want to take our judgment and force it onto the family. Sorry. So I remember putting it in the hands of the son. We went with the medication, crushed in applesauce, and we weren't seeing improvement for the first 2 days. And I found out the med techs were trying to give all the other meds first, the patient spitting it out. So I had to take the med techs aside individually and in a group when I could. Antibiotic first, whatever she can get in, and then if she spits out, stop, reapproach later. Don't give the other meds. But because they focused on the antibiotic first, then we started to see micro improvements that eventually became improvements that eventually got her back under baseline. So she never got back to baseline, but she did improve. Again, paying attention, just being involved, improved patient outcomes. Um, I do need to, as I'm going over this with you, I do want to get back into this chapter again. It's a draft, but giving you alternatives, comparisons out there, and then looking at the outcomes and key lessons. As you were reviewing as we're scrolling through, I mentioned about gabapentin can be an issue with end-stage renal failure. So let's look at that as a case study. I'm not going to read this out. I'm trying to go slowly as I'm talking with you. And when the book is out, and I'm not trying to be offensive whenever I say buy the book or sales-ish, so to speak. I'm humbled by everyone who buys my books. I'm humbled for those who promote. I'm thankful for all of you. But this isn't meant to be here's an ends all means. It's just this is an overview, and if you learn from the overview, wonderful. If you learn enough that you don't have to buy the book, that's okay too. I'm just trying to share. So this is looking at a scenario, again, trying to take in what the assessment looks like, what half-life can look like. One of the things I like about the writing the books and being the geek that I am is I did not know this before. Like some of this I knew and some of this I didn't know. So like the gabapentin half-life, that was one of the ones that was like, didn't know it can go out that far. And so that does get into looking at, what do we need to do here? So how that communication might look with the provider, because I mentioned in the early on with this book overview, I want to accomplish several things: a better understanding clinical pharmacology at the end of life, specific to the end of life. Then there's the case number one. We as nurses want to call the provider to instigate, impart, start change. So what does that look like for that SBAR? Situation, background, assessment, recommendation. And the second thing, and this is going to more likely a case would occur in facilities where we walk in and we get an updated med list. When did this happen? Or even in those home patients where, for better or worse, and I don't mean this in a negative way, but you know how you can have helicopter parents for their children, where you can have helicopter parents as caregivers, helicopter caregivers, where they're very involved for good and bad. And I'm not saying that from a judging standpoint. I called it, like, I've had patients like this even, last year, my patient who had an abdominal aortic aneurysm that was close to 4 centimeters, where the daughter called the provider and got brand new orders. And I was seeing this patient like 3 times a week, and like I get there for the next visit, and we got a new order. I thought we talked about this last. Okay. Like I didn't say it that way, but in my head, I'm going, gee, okay. But you have to deal with those. And sometimes they're on track. Applaud them, encourage them. And you want to encourage them no matter what. I rarely try to put the brakes on because I don't want to enter. This is not about judging them. They care. But there are times like saying, we need to tweak this. I appreciate you care, but a little bit the wrong direction. Let's tweak it. So, here's why for the rationale. For those who are newer nurses, one of the reasons I like UWorld when I was preparing for my boards is I like UWorld because it said, here's why it's the right answer, but here's why the wrong answers are wrong, and here's when they might be right. So I'm trying to give the rationale and the expected outcomes for that. Case study is looking at NSAIDs. And again, what that S bar might be with the provider and the rationale, along with some follow-up monitoring. Then I believe this is the last case study that we're getting into is morphine. And getting into clinical signs. Looking at risk assessment. Again, what that S bar should look like. When I say should, this is just my brainstorming with you. And one of the items that's going to be in this book, and I did put it out there in two hospice Facebook groups. The final version will be ever so slightly different than what I posted in the hospice nursing support groups. I remember that I included some wording in my bullet points that I said it's related to fentanyl patches in particular when it was just an overall clinical notes in that. Uh, but there's going to be an opioid conversion chart, including fentanyl patches. Now, what's going to be different from my opioid conversion chart as compared to the charts that are out there all over the internet is the charts out there over the internet will say if you have this much of oral morphine in 24 hours, that's the equivalent of 6 micrograms of fentanyl an hour. Okay, is there a 6 microgram fentanyl patch? No. Now, I know one of you are going to be, and I don't mean this as a hand slap. I repeat, I don't mean this as a hand slap or a wooden spoon. I might remember my mom with the wooden spoon, broke it over me several times. But I know somebody's going to say you could take a 12 microgram patch and cut in half. I'm not your boss or your mother or your dad. Don't go there. There are pharmacists who will argue that, and there are pharmacists who might give you the nod. But there's not a 6 microgram patch. So there are certain patches out there, and I don't have the part of the reason I'm a list person, my short-term memory is like this. And my long-term is better, but I don't have every patch strength memorized, but I believe it's like 12, 25, 37 and a half, 50, 75, and I don't know if there was an 87 point whatever, and 100. But you can combine patches. So I have that out there that's what makes mine different is I just focus on available patches and have notes that you could have up to 2 patches on a person and some learning outcomes. Then we get to all the conclusions. I do have discussion questions. I am still working out. One day I'd love to be able to have courseware. Red just means I have Grammarly. Let me go adjust that while we're here. Um, Practice scenarios and Socratic questions for learning. So that's it for this portion of the overview. I'll end in the outro. Thank you for your time watching that overview. Please, if you have any questions, you see anything wrong, you think I'm an, as it relates to the book that you're overviewing, gee, you're an idiot about this or that, you're not going to hurt my feelings. I appreciate the input I get from every side. I like to consider different points of view. Just an update for those who are following me that really do that appreciate my books, that have been buying and reading them, promoting them, whatever. Appreciate you. I'm humbled by you, and I thank you. I am working on, I'm juggling, so to speak, not that I could physically juggle balls, so to speak. I'm juggling writing 2 different books at this time. I have Hospice Clinical Pharmacology that you now saw the second overview. I'm also writing a book called Hospice Tools of the Trade. The title is kind of inspired by the upcoming April of 2025 Alabama Hospice and Palliative Care Nurse Conference. I believe it's in Hoover, Alabama, with Shelley Henry of the Amity Group. And they have so many good speakers, and this is a wonderful event. So if you're interested in that, it's wonderful to go. I'm tempted to go myself. I'm not sure that I want to drive 6 hours, stay overnight, as tempting as that is for the speakers. But we have a lot going on here in Kentucky. But I'm writing a book, Hospice Tools of the Trade, that's going to be focused on in what you could print out and have as part of your clipboard. I love these because they're like, oh, you could HIPAA, yeah, fold. It actually does. Sorry about this slam. Does fit in your scrub pocket, but I'm writing 1 to several, like a small number of page handouts that this will be an 8.5 by 11 book that can be printed out. I have put some of the PDFs of this in 2 of the hospice Facebook group, nursing support groups that I participate in. There's going to be opioid conversions. It's part of the Hospice Clinical Pharmacology book. I have my most favorite, so speaking of favorites, but I have one of my best brain sheets for hospice nurses that's going to be in this book. I'm going to have here are questions you should be asking during the admission. Like how do you come up with how many times should the case manager, which might be you, how many times should the case manager see this patient when this is the first time you're laying eyes on them? There's evidence-based methodology for you to know that without rolling the dice or relying on somebody saying, well, our standard is, no offense to standards, patient-centered care, what's individualized for your patient. So there's a methodology for this. So part of this Tools of the Trade book are going to be, here are admission questions to ask, and here's a framework for your initial plan for the nurse. There's going to be handouts for looking at recertification comparisons. This is what they were like at admission, first benefit, second benefit, and so on. So that book's in progress as well. I'm hoping to have both of those completed by the end of April, but I'm trying to be very focused on the quality of the work versus how fast I can publish these documents. Coming to a close. Thank you so much for your time. If you like what you see, if this is something you want to continue getting updates on, subscribe, put the bell on below, and ask questions. I had a hospice nurse reach out to me via Facebook Messenger. What do you know, she works at an inpatient unit. What are my thoughts on CNA care plans? And as we have these brainstorming sessions, I don't know it all. I don't have all the answers. What I do have is I love and I adore hospice. I love and adore all of you who work in hospice. We're colleagues. Let's brainstorm together. Let's lift up one another. Let's encourage one another and bloom and grow. And that's where I'm coming from with the books, with what I write at compassioncrossing.info. Side note on that little rabbit trail, one of the daughters on the Hospice and End of Life Facebook group that's more specific for patients, caregivers, and families, but a number of hospice personnel participate, was so concerned over her dad, hi Ash, if I'm pronouncing her name correctly, that he had immunotherapy for esophageal cancer, but now he has tremor so bad that when he's eating and drinking, he's just so fatigued. So I'm a geek at heart. I'm a nerd, and I don't view that as bad things. I think I'm autistic too, undiagnosed. But here I am. I researched what are the best methodologies for supporting a loved one that's no longer on the immunotherapy, that is on hospice and now facing end of life. And so you'll find that article on compassioncrossing.info. I normally publish Monday, Wednesdays, Fridays, but I did publish that article yesterday. Uh, and it's not just for Ash. That was also a memory of Greg, my esophageal cancer patient who literally asked me to kill him. One of my most ethical, challenging cases. Did not kill him. Did write about him, and that you could have faith in hospice, faith in nursing. But I'm ending here. I do thank you for your time. I hope you have a great day, and bye.